Hello, Loving Health community. My name is Kate, and I have another newsletter article for you today with general health information. So, if you would like these articles sent straight to your email every 2 weeks, I can get you signed up right away at lovinghealthforme@outlook.com. I can also give you the references to the information in this article. So, today's newsletter is called Hormone Replacement Therapy Increases Risk of Breast Cancer. Hormone replacement therapy, or HRT, is the process of administering exogenous synthetic or bioidentical hormones into or onto the body. It is also known as menopausal hormone therapy or estrogen replacement therapy. During menopause, estrogen and progesterone levels decrease, which play a role in fertility, cell regulation, and bone building. Because of this decrease, many women may gain excess adipose tissue or excess body fat, particularly in their midsection, which produces estrogen and can serve to compensate for the loss of the hormone made by reproductive organs. So when your ovaries are no longer producing estrogen needed by the body and you gain this midsection fat, it can actually help to compensate for the loss of estrogen because the adipose cells or fat cells do produce estrogen. This type of hormone therapy is marketed towards helping menopausal women with uncomfortable symptoms during their transition, such as hot flashes and vaginal dryness. HRT is effective at providing relief from these short-term symptoms, but it does come with risks. The Collaborative Group on Hormonal Factors in Breast Cancer conducted an analysis of all published and unpublished data from eligible epidemiological studies on breast cancer risk with HRT from 1992 to 2018. They stated that previously published data on HRT and breast cancer risk were unable to reliably assess the association between breast cancer risk and current users as well as ever users or past users, review the totality of the evidence, or they could not carefully control for potential biases and confounding factors, which is very important. This group's analysis assessed differences in risk for the incidence of invasive breast cancers in over 143,000 postmenopausal women using HRT with past users and never users of the therapy. So not just women who stopped using the hormone replacement therapy, but women who had never used it, and comparing their risk of breast cancer. Of the women included, 90% were in menopause by age 55, and women with hysterectomies were excluded. In the 58 studies analyzed, over 424,000 controls were included that were not diagnosed with breast cancer within the time frame, of which 71,217 were never users, so they have never used HRT. The resulting risk was adjusted for ethnicity, education, age at onset of menarche or when they got their period, height, oral contraceptive use, but the results were unaltered, so none of these factors changed the results that they got. Findings from the analysis concluded that every type of HRT increased breast cancer risk. The longer the duration, the greater the risk, doubling after using HRT for 10 years compared to 5 years. Though the duration of 5 to 14 years showed the greatest increased risk of estrogen receptor positive invasive breast cancer, the risk was still significant after using HRT consistently for over 1 year compared to never users. So there can be different types of breast cancer, and estrogen receptive positive cancer accounts for about 75% of breast cancer cases and deaths in Western countries. So this is the majority of breast cancers that people are diagnosed and dying from. The cancer risk was significantly greater with estrogen progesterone products compared to estrogen-only products, whether the progesterone hormone used was synthetic or bioidentical. So in the hormone replacement therapy that these women were using, there are different kinds. There can be only the estrogen hormone being used, or there can be a combination of estrogen and progesterone. And remember, estrogen and progesterone both fall during the time of menopause. So the ones where they were using both of the hormones raised the risk much higher than the estrogen only. Even though the estrogen only was still increasing the risk, it was the two combined that showed a greatly increased risk for invasive breast cancer. The only exceptions to this increased risk were topically applied HRTs or suppositories and using HRT for less than 1 year. So if it did not have a systemic effect on the body, it was only absorbed topically, it did not have a dramatic increased risk, and also if it was used consistently or inconsistently for less than a year, it did not have the increased risk. The researchers stated that they did not know why estrogen-progesterone products yielded a greater risk compared to estrogen-only products, but accepted the trend as it was consistent with and confirmed by other studies. A proposed mechanism of action could be explained by Otto Warburg's seventh hallmark of cancer. And if you're unfamiliar with this, it is that cancer cells ferment glucose in the presence of oxygen, and this is a behavior which is not practiced by normal, healthy human cells. Simply put, cancer cells take up a lot more glucose than normal cells, which can be seen on a positron emission tomography or a PET scan and can be used to diagnose cancer to see if it has spread to other parts of the body. So you might be familiar with this PET scan, and it is used while trying to diagnose cancer and see where the glucose is being taken up in the body and to see if it has metastasized or spread to other parts of the body. And they can tell because they can see on these scans which cells are taking up huge sums of glucose, and that is a characteristic of cancer cells. They use up a lot of energy compared to the other cells, and they can see it on there. A long-known side effect of taking exogenous steroids is a sustained spike in blood sugar or steroid hyperglycemia. Having excess glucose in the blood for sustained periods of time on a consistent basis may very well be feeding pre-existing cancer cells and providing them with fuel that otherwise would not be available. Even though progesterone is naturally produced and needed by the body to function properly, it is classified as a steroid, and taking exogenous steroids that have a systemic effect on the body for a prolonged duration could have long-term implications and consequences to health that research is only starting to uncover. The message is clear. If reducing breast cancer risk is a priority, hormone replacement therapy is not a great option for managing menopause symptoms. But what about if you've already started? Does your risk of invasive breast cancer decrease or return to baseline after stopping hormone replacement therapy? It may depend on how long it was used for. The Collaborative Group on Hormonal Factors in Breast Cancer's analysis stated, quote, after ceasing MHT, some excess risk persisted for more than 10 years. Its magnitude depended on the duration of previous use, with little excess following less than 1 year of MHT use, unquote. However, a prospective study from the UK of over 1 million postmenopausal women found that breast cancer incidence risk for current users of hormone replacement therapy eventually returned to that of never users after stopping the hormones. Their risk was still statistically elevated 2 years after stopping, but then reduced up to 14 years after use ceased. So for about 2 years after stopping the hormone therapy, their risk was declining. It was still elevated compared to women who had never used the therapy before, but it was declining. And then at the 2-year point up to about 14 years, their risk had returned to those who had never taken the replacement therapy before. So that should be incentive to stop if you feel that this is the wrong therapy for you and you would like to reduce your risk of breast cancer. This study also showed that breast cancer risk was greatest for younger women starting hormone replacement therapy during or up to 5 years after menopause. So it does matter when they started the hormone replacement therapy. So when HRT is off the table, what can help to mitigate menopause symptoms? Exercise has been shown to reduce the incidence of hot flashes, including resistance training and yoga. Besides reducing the body's basal core temperature and increasing its sweating capacity, exercise helps with losing weight. Being overweight or obese can increase severity of symptoms such as hot flashes, vaginal dryness, and joint pain. Exercise also lowers cancer risk. So exercise is not only a great way of mitigating these symptoms, but can help you reduce their incidence in the first place during this transition. Menopausal symptoms such as hot flashes have been found to occur less frequently in Japan compared to Western countries. Although it is possible that cultural differences in symptom reporting played a part, differences in diet were thought to be the most influential. The traditional Japanese diet prior to 1945 was abundant in rice, legumes, vegetables, and low in dairy and animal fats and oils, which is similar to a Loving Health style diet. As Japan's diet has become more westernized in the last century, the reports of hot flashes have doubled. A randomized control trial of women eating a low-fat plant-based diet demonstrated a reduction in the frequency of moderate to severe hot flashes. Although the number of participants was small and duration was only 12 weeks, about 60% of the women reported that they no longer had moderate to severe hot flashes by the end of the trial. There were 0 reports of this in the control group. Although HRT may negate menopausal symptoms in the short term, it increases cancer risk in the long term. Keeping off excess adipose tissue, exercising, and eating a health-promoting diet can help with symptoms and reduce cancer risk, as well as risk for other chronic diseases. And a note to women who may not yet be concerned by this, many forms of oral contraceptive pills are also exogenous estrogen, progesterone hormones that have a systemic effect on the body, not just on the reproductive system that they are marketed towards. Consistent long-term use is not without risk. So that's it for today. If you found this information useful, please like and share this video and subscribe to our channel. And if you would like these newsletter articles emailed straight to you, reach out at lovinghealthforme@outlook.com and we will get you signed up right away, and you will get the references as well so you can look up all of the studies and information that I referenced in the article. I hope you have a wonderful day, and I'll be back to you next time with another article. Bye.